Hello, doctors. A very good evening to everyone. So we are here on the platform to take a webinar on the case of infertility in females. Let me introduce you to our speaker, Dr. Partha Chakraborty. We are welcoming Dr. Parth on our platform to enlighten our knowledge on the topic of female infertility. So let me give a brief introduction of Dr. Parth. Dr. Parth is a renowned homeopathic physician in Durgapur who specializes in chronic cases. He has done BHMS and B.Sc from Calcutta University and MD in homeopathy from B.R.A. Bihar University. He has fellowship of Faculty of Homoeopathy in Malaysia. He is a postgraduate professor in international PG course of Classical Homeopathy, that is in Loyola University in Bolivia. Dr. Partha is a former associate professor in Department of Homeopathy in Lincoln University College, that is in Malaysia, and former assistant professor at BV Homoeopathic Medical College, India. And he's a former visiting faculty to PPHM at Malaysia. So we are welcoming here on the platform to Dr. Partha Chakraborty, who is enlightening our knowledge on the topic of female infertility. So, sir, there are many audience. So I think we can start our webinar now.
Yeah. Thank you. Am I audible, Dr. Bharti?
Yes, sir, doctor, you are audible.
Okay. Okay. Thank you. Thank you, Dr. Bharti, for introducing me to the learned audience over here. A very good evening to all the listeners, to all the viewers, to all the doctors, to homeopaths, to enthusiasts over here. We have gathered over here to study, to know about a particular disease that's called female infertility. And this problem is getting increasingly, we are finding it in our clinics every day. As homeopath, I always tell to my audience, to my students, that as homeopaths who are practicing nowadays, we have very little choice in selecting what sort of cases we'll see, but definitely we have some preferences, which sort of diseases we prefer to see, or we are very interested for these particular subjects. And this particular subject, this female infertility, is a very interesting subject for me. Because if I remember correctly, I started my practice over here, besides teaching, I started my practice over here in 1996. And in 1997, I saw the first case of infertility, I remember. The first case of infertility in my life, I saw the first time in 1997. That particular boy now is around more than 28 years old. And the very recent case that I've solved, that boy is only just 1 month old. I'll show you that case. So this is very interesting. So I've been seeing this sort of cases for the last many years, many sort of cases. In many cases, I've succeeded. In many cases, I have not succeeded due to many reasons. Anyway, I would like to share with you my experience, what I have seen in female infertility cases. Before I go into the female infertility cases, just a brief roundup of the female reproductive system. This is the picture. This is the uterus. This is the fundus of the uterus. This is the body of the uterus. This is the cervix, and this is the vagina. Now, after the intercourse, what happens? The sperm actually gets inside the vagina. It's deposited in the vagina. It swims upwards. And let me put the pointer. Yeah. So the sperm actually swims upwards like this into the cervix and finds its way into the uterus. And then gradually it finds its way into the fallopian tube. And on the other hand, this is the ovary. From the ovary, a matured ovum or an egg is released. It's taken over by the femora and it's carried through the fallopian tube in this way. So in the fallopian tube, what happens, the ovum comes like this, and the sperm swims across the, this is an upstream swim by the sperm, with the help of some muscular contracture, by the help of some hormonal influences, it goes up, and the ovum and the sperm, they get fertilized over here in the fallopian tube and forms a zygote. And that zygote comes down in the uterus and settles down on the endometrium. That is a normal female reproductive system, and this is how female gets impregnated. So this is the overall picture of the female reproductive system. It's not so simple as I have shown over here. It's a very complex mechanism. It depends on some muscular factors, hormonal factors, all sorts of factors are involved, but this is a very simple picture that I've shown you. If there's any problem in this particular process, anywhere, it may be an anatomical problem, it may be a hormonal problem, it may be anything which causes a hindrance, then we'll get a case of infertility. So what is fertility? Before we go to infertility topic, let me tell you what is fertility. Fertility is the ability to reproduce specifically to conceive and bear offspring. Very simple definition, because a particular species goes on because of this particular unique character of fertility. The unique character of fertility is actually responsible for a species to go on. So we are Homo sapiens, we are also carrying our species forward with the help of this mechanism, where a female has got the ability to reproduce with the help of a male, that is specifically to conceive and bear offspring. Now, then we come to what is infertility. What is infertility? Infertility is defined as the inability to conceive a child after 12 months of regular unprotected intercourse. This is a very, very broad definition of infertility. If anybody asks you what is infertility, then the answer will be it's the inability to conceive a child after 12 months of regular unprotected intercourse. That's a very general definition of infertility. Why I'm telling you the definition? If, say for example, if after a marriage, for 1 or 2 months, a couple comes to you and tells you that we are trying for a baby and we are unable to, my wife is unable to conceive. So that's not a case of infertility. They should spend a time of at least 12 months of regular unprotected intercourse, and then only we can diagnose it as a case of infertility. How common is this problem? I told you in the very beginning that this is a very common problem. I've been seeing it for the last from 1987 till today. Even day before yesterday, I got a case of primary infertility. So this is all becoming very common. Statistically, I can tell you that around 10% of women is suffering from infertility problems, and I think this is going to increase day by day with the increased number of use of oral contraceptive pills and other things. Now, there is a criteria in diagnosing female infertility. If you go by the diagnosis, the criteria is 12 months. But I've seen in some books it's mentioned that the criteria for females who are over 35 years, because we are seeing nowadays, we are seeing cases who are young women, young couple. We are also seeing cases where the mother, would-be mother, or the mother is trying for a second baby who is over 35 years of age. So in these cases, where the would-be mother or the mother is 35 years old, more than 35 years, the criteria of diagnosing female infertility will actually reduce down to 6 months. So if in that case, if we find that after 6 months of time, regular unprotected intercourse, the female is unable to conceive, then it will be a case of infertility. And in case where the female is less than 35 years, it's as usual 12 months. I remember just around 2 months back, I got a case. I can remember the woman is around 40 years and the male is around 45 years. They came to me and they told me that we are trying for a baby. I was very astonished initially. I asked, don't you have any baby? They told, yes, we are having 2 girls. Now we are trying for a third one. If we get a son, then we'll be very happy. This is a stigma that's going on in the Indian society till now. Anyway, so that case is actually the aged lady is over 35 years. So we will will diagnose the female infertility when they're trying for more than 6 months and they are unable to conceive. So it's a case of secondary infertility. I will come to the definition later on. So we are seeing all sorts of cases, this sort of things. What are the types of infertility? There are basically two types of infertility. One is primary infertility, another is secondary infertility. What is primary infertility in females? The primary infertility in females is defined as the inability to conceive after 1 year of regular unprotected intercourse. This is very, very important. You have to know when they are married, since when they have been trying to have a baby. So this time frame is very important in diagnosing these cases. So this is called primary infertility, where the female has never been able to conceive. Say, for example, a female conceives and due to any reason gets an abortion, abortion after 2 or 3 months. That will also be considered as a case of primary infertility. Secondary infertility in females is defined as the inability to conceive after a previous successful pregnancy and giving birth. So if a woman has conceived but has aborted by any reason, it might be a case of medical abortion, it might be a case of accidental abortion. So she hasn't given birth to a baby, so that will be considered as a primary infertility. And if they have given birth and now they are trying, but now they are not being able to conceive, that's a case of secondary infertility. Now, what is the presenting symptom in infertility cases, female infertility cases? In each of the diseases, patients come to us with some definitive signs and symptoms. So over here, we'll be discussing about the presentive symptoms in female infertility. So the most common presenting complaint in these cases is the inability to conceive. That's the most common presenting complaint. The doctor, we are married for this much years. We have been trying to get a baby, but I'm unable to conceive. That is the most common presenting complaint. Associated with that complaint, because we as homeopaths, we have to build up a totality. We have to treat the patient holistically. So we have to take into account all the other associated symptoms, which may be the menstrual problems. Even the menstrual history has to be taken. If there's any problem, that has to be taken. If there are any hormonal problems, if the patient is suffering from hypothyroidism, if the patient is suffering from hyperprolactinemia. So these things are to be taken into account. If there is any uterine or ovarian problems, all things have to be taken into consideration while we take up a case of primary infertility. And the thing which is very interesting for me nowadays is the associated psychiatric evaluation. A patient, when comes to us with primary infertility or secondary infertility, we have to go through the psychiatric symptoms, the mental symptoms, as we have been taught in our organ of medicine, the mental symptoms of the psychiatric status of the patient. That has to be taken down in details, very sincerely and very rigorously, because these things might help in selecting the medicines. We'll be discussing on this particular thing in today's topic, because this is a very, very big topic. I won't be discussing much on this anatomical problems, but I'll be discussing more on the psychiatric or the mental symptoms. So the biggest challenge that we find nowadays is a psychosocial aspect faced by the would-be mother. In case of primary infertility, the woman faces some psychosocial problems. In case of secondary infertility, if the mother has given birth to 2 or 3 daughters and is unable to give birth to a son, she also faces some social stigma. So that's a big challenge, and that society looks upon at that poor woman with suspicion that she is not being able to give birth to a boy, or she is not being able to give birth to a son or daughter. And even in the rural areas, we have seen that family members, they blame the woman for not conceiving. It might not be her problem. It may be a medical problem. That is not her fault. Medical problem, medical disease is not anybody's fault. But still, she is being blamed for not being able to conceive. So these things, and in that particular state, what is the state of the mother, what is the state of the woman, that has to be considered. That is very, very important. And infertility is the biggest stigma faced by the women. We are seeing, I'm seeing in my practice that the women, they're coming. Just 2 or 3 days back, one lady came to me. She is around 34 years by age, and she has not been able to conceive since she has been married in 2021. Now she is seeing her colleagues, they are having baby, her friends, they're having baby, and she is suffering from a depression, from a social psychiatric problem. So these things has to be considered in our case taking very, very importantly. Now, what are the consequences that the patient faces, psychiatric consequences? Number one, increased stress, anxiety, and depression. All these things, the thinking, they lead to increased stress, anxiety, and depression. And ultimately, due to prolonged depression, prolonged anxiety, prolonged stress, the patient loses self-confidence. There's a big impact on the self-esteem and loses self-confidence. And sometimes this infertility with the depression is associated with eating disorders and other addiction and disorders of sexual functions. I have also seen in my practice cases where the couple has been trying to get a baby for years together, and finally, with the depressive state in the mind of the woman, what happens, after some time, the woman develops aversion to intercourse. So this sort of disorders of sexual function, aversion to intercourse, these things are to be taken into account in these cases. They have to be counseled. They have to be told that, no, you have to try. I've been helping you, and you have to try sincerely. So in managing female infertility cases homeopathically, come to the second point first. We have to take the physical symptoms, whereby we have to note whether there is a problem in the ovary, whether there is a problem in the uterus, whether there is a problem in the hormonal status of the patient. So these things has to be taken care of. And besides this, the mental state of the patient, the psychiatric analysis, the psychiatric assessment of the woman has to be known in details. Because this, I think, is the most important concomitant in solving infertility cases. If we go through Boger's writings, we have seen that Boger has always emphasized on concomitant symptoms. And in these cases, though people come with the common complaint of infertility, they will be presenting with tons of papers before you that you see, I've gone through n number of times of USG, I've gone through n number of times of hysterosalpingography, all sorts of investigations I've done MAMH, I've done this sort of things. But with these things, you have to convince them that what I'm asking, please answer me sincerely, because this psychiatric assessment is very, very important in solving your case. Then only we'll be able to manage female infertility case successfully. Now, what are the causes of infertility? This has to be known, because once we see the case, we have to know the cause, because Hahnemann has always emphasized on the cause, be it fundamental cause, be it acute cause, be it maintaining cause. We have to go for the cause always. What is the cause of infertility? If we can solve the cause, if we can reach to the cause, then we can solve the case. Caesar causa, Caesar effectus. Hahnemann has already told. Now I have classified the causation of female infertility into 4 points. The first problems might be with ovulation. The second might be with some structural problems. The third might be hormonal imbalances. And the fourth will be other factors. The first 3 are very important: ovulation problems, structural problems, hormonal imbalances, and other factors. Ovulation problems. In ovulation problems, the most common thing that we find, the most common cause that we find in female infertility cases in our clinics is polycystic ovarian syndrome, which is known as PCOS, polycystic ovarian syndrome or polycystic ovarian disease. This sort of cases are coming to us regularly. Then it can be a case of primary ovarian insufficiency, where the ovarian response is very, very poor. This thing particularly we find in cases where the female has become aged, more than 35 years of age, and there is a poor ovarian response. That means the egg quality has diminished. The number of eggs that is being produced by the woman during the ovulation is very, very less. So this thing is also causing problem. Hypothalamic dysfunction, that means the hormonal effect due to hypothalamic dysfunction can cause infertility. And irregular or absent periods. Why irregular periods are very important? Because when the female is suffering from irregular period, they do not know when the ovulation is taking place exactly. This fertile period, this fertility period, is not the entire month. The entire month is not fertile. There's a particular time when the female becomes very, very fertile. So if there is a regular period, you can assess what is a fertile period. But if the periods are very irregular or the periods become absent, you cannot identify the safe period or the unsafe period or the fertile period. So these ovulation problems are very important to identify in solving cases of female infertility. Structural problems means anatomical problems, where you can find, if you remember the first diagram that I showed you, if there is a damage in the fallopian tube or a blockage in the fallopian tube due to any infection, due to any inflammation, due to any tumor, due to any extra uterine growth, anything it may be, it is causing fallopian tube blockage or fallopian tube damage. What happens, the sperm gets inside, the ovum is released, but they cannot come together. They cannot form a zygote. So that can also cause structural problems. Uterine problems, if the female is suffering from a huge, uterine fibroid, which is causing an obstruction in the free flow of sperm to the fallopian tube, it can also cause female infertility. Endometriosis is a very common problem. We are now seeing very young women, they are suffering from endometriosis, and this endometriosis is a very, very big cause of female infertility. We have to solve these cases. These cases are coming to us on a regular basis. Pelvic adhesions. It can be a case of fibroid, adhesion in the uterus, adhesion in somewhere else. So these pelvic adhesions are also very important structural problems which are causing infertility. The third cause is a hormonal imbalance. Disruption in production of regulation of hormones. Now, FSH, then your estrogen, progesterone, FSH, LH, these hormones, they are having specific functions in in ovulation, in preparing the endometrium, in helping the during the fertility, during the fertility of the ovum and the sperm. So if there is a disruption of any of the hormones, say for example, if there is a problem with the progesterone, the endometrium will not be properly, what I will say, the endometrium will not be in a proper shape to receive the zygote. So in those cases, it might happen that there will be premature abortions. So this we have to ensure that the hormones are regularly produced and there is no disruption. High prolactin levels. I have mentioned specifically about prolactin because these cases are very, very common nowadays. I have seen many cases where the female is suffering from hyperprolactinemia due to any cause. And if you get a case of hyperprolactinemia where the prolactin levels are high, go for an MRI of the brain, because very often we find that some pituitary adenomas are there which is causing extra prolactin, and that high prolactin levels actually inhibits proper ovulation. And thyroid problems are very, very common. If the TSH levels are more, it inhibits ovulation. So female infertility can also be due to excessive TSH in the blood. Other factors are age. I told you that if the female is more aged, then the chances of getting pregnant or conceive, chances of getting pregnant is very less, because the number of eggs becomes less, the quality of eggs becomes very less. And we can assess the quality of the number of eggs by a particular test that is called AMH, anti-Mullerian hormone. Lifestyle factors, those who are actually going to the pubs, going to the clubs and spending nights, not taking proper rest, they are more likely to suffer from infertility problems. Medical conditions like diabetes mellitus, tuberculosis, they are very, very common in producing female infertility. So you have to know all these things, you have to keep in your mind when you are seeing a case of female infertility. Genetic or chromosomal disorders. I have seen cases where the female gets pregnant and suddenly after 2 months, there's a sudden abortion. That's called blighted ovum. These cases are genetic problems. If there is a defect in the genetic structure, or there is a chromosomal disorder, then suddenly, without any precursor symptoms, the female might suffer from abortion. That's called blighted ovum cases. So that's due to chromosomal disorders. And sexually transmitted disease, they can also cause infertility problems. This was a brief discussion about female infertility, the definition, the types of infertility, the causes of infertility. And now we will be coming to the case studies. I'll be presenting two cases. I've selected two cases to be presented over here. The first case is a patient who is 32 years old, female 32 years old, already crossed 30 years. She was from Mumbai, I remember. The date of first visit was on 9th of October 2024, just a very recent case. Last year, after the Durga Puja, she came to me. Before the Durga Puja, I think she came to me. 9th of October 2024. She has been married for 6 years and they've been trying for a baby for the last 2 years. So for the first initial few years, they didn't try, but now they have been trying vehemently to get a baby, but they are unable to conceive. And they have the female has never conceived. Why have written never conceived? Because by this thing you can diagnose whether it's a case of primary infertility or it's a case of secondary infertility. So definitely this is a case of primary infertility according to its definition. And there has been no history of intake of oral contraceptive pills. This usage of oral contraceptive pills are very important. Now, in the initial 4 years when they have not been trying, there is a high probability that the couple had been taking oral contraceptive pills, and these things in the long run can produce some sort of infertility problem. Even before marriage, if the female had been suffering from some irregular periods or menorrhagia, sometimes they are given by the gynecologist some oral contraceptive pills to stop the pregnancy or to regulate the pregnancy. So these medicines actually have a toll on the female anatomy, female genitalia, and finally these patients suffer from infertility problems. So I have taken this history that they were not taking OCPs. These points you have to remember and you have to take while you take the case. The menstrual history is very important. When did she start menstruating first? It was in the 14 years of age. So she started menstruating slightly late. Normally in India, in tropical countries, they start after between 9 to 11 years. And she started at around 14 years. It was a slightly late menarche, but the menstrual period was regular. But amount is less. Now, presently, the menstrual period is regular, but the amount is less. And average duration of each period is 3 days. Regarding pain, she gets pain on the first day. So this is most likely a case of congestive dysmenorrhea, and she needs painkillers. No prominent or history of premenstrual tension or mood swings. This is also very important history that you have to take into account. Nowadays, we see that premenstrual syndrome, that is before the period starts, the female suffers from some sort of anxiety, some sort of mood swing, some sort of heaviness of the breast, pain in the breasts, some sort of acne on the faces. So these are all known as premenstrual syndrome. So there was no history like this. The last menstrual period when she came to me was 27th of September 2024, and it was of 2 days duration. So the duration is less actually. 27th of September. Other symptoms, in the past medical history, I've got that she was suffering from childhood tonsillitis. Father has a history of type 2 diabetes mellitus. Mother has a history of hypertension. Stool, she is suffering from constipation. That means she is not having soft stools, she is not having regular stools. She needs some fibrous foods to relieve the constipation. Urine, there was no abnormality in the urine. Perspiration was moderate and appetite was normal. I asked in the details, but there was nothing mentionable. So I have written NAD. Other symptoms, profuse leukorrhea for the whole month. So this leukorrhea or white discharge or cervical discharge is very important in cases of female infertility. So this leukorrhea was thick and it was continuing through the whole month. And she was always tired. Actually, she was a actually office-going lady, and she was always tired. Whether she is going to the office in the morning, when she was coming back from the office, she was very tired and she was fatigued always. Even during the office hours, she was getting very, very tired and fatigued. Morphological appearance, she was a fair lady and moderately built person. Mind. Now, come to the mind symptoms later on because you have to gain the confidence of the patient. Now, when you have gained the confidence of the patient understands that yes, you are trying to help her sincerely. Now, it might happen that she will be opening herself up to you. I got some symptoms. There was a long-standing anxiety because this particular lady, she was staying in Mumbai and her parents were staying in my city over here. So it's a far away distance. A normal flight takes around 2.5 hours and a train journey takes more than around 40 hours to reach this place from Mumbai. So, and being the only child of the parents, she had a long-standing anxiety for the parents who are aged and who are not keeping well. So that's an anxiety I got for the patient. Associated, additionally, there was office stress, work stress, and a lot of commuting stress. She had to change 2 autos to go to reach the office. And recently, she was suffering depression. This depression was ever increasing. Why? Because with each passing menstrual period, she was suffering from depression because, oh, once again, another period has gone. So this month also I have failed to conceive. So this ever increasing depression with ever passing menstrual period or utter sadness during menses, because the menses was signaling that she was not being able to conceive. That was causing increasing depression in the lady. And while I was asking the lady that, tell me something more, I can find a symptom where I found that she was suffering from downward. She had a fear of downward motion. This is a very peculiar fear that I got in this particular patient, because this type of fear, which has no direct, relation to the main problem, they are very important in solving the cases. Pathological investigations, they already did some investigations that they did, because these cases, they don't come fresh to us. They will go to the gynecologist, they will take medicines for 1 or 2 years, and then they will come to you. So this was the latest. Pathological report. Serum prolactin was 27.26, marginally high, not very pathologically significant. Serum TSH levels 2.6, and USG of the abdomen was done. Fallopian tubes were patent. Uterus was okay. It was done in July 2024. And I asked for the husband semen analysis. This is also very important. You have to know the status of the husband also. The morphology of the semen was normal. 75% of the semen was normal, having normal morphology. Motility was 60%. This assessment is very, very important. Whether there is agiospermia, whether the sperm quality is good, whether the sperm is having significant motility, these are very important in solving these cases. If the husband is having problem with the motility, then you have to treat the husband also. Now, the main thing, that is the finding the remedy. We have got a case. We are having a case in our hand. Now we have to find the remedy. Now, finding the remedy, RadarOpus helps me very much. I'm using RadarOpus. I've been using RadarOpus for a long time regularly, and this is helping me very much. You can see this is a screenshot of the Repertorisation sheet. I've taken the main symptoms with which the patient came, that is female genitalia, sterility, for 147 drugs. Then I'm just, coming down, I'm closing down female genitalia, sterility with leuko. One thing I just forgot to mention, that though we are talking about infertility, that's a medical term that we are dealing with. But in the repertory, you will not find the term infertility. When you open the repertory, you will find the term sterility. So that's the homeopathic, term for infertility in repertory. You have to look for sterility. So sterility with leukorrhea, 6 drugs are there. I've gone to leukorrhea rubric. There are 508. They are very general rubrics. You have to take the general rubrics first. Kent has always advised that first you take the general rubrics, then you come to the sub rubrics. Then I've taken general's weakness. This weakness was very, very important in this lady. Fatigue, weakness, tiredness. So I've taken, and this weakness we'll find in general's chapters. And this weakness is particularly felt after exertion. Even slight exertion is causing weakness. So I've taken this sub-rubric also. It's covering 19. It's covered by 19 drugs only. And then finally, I've come to the concomitant symptoms, that is the mind symptoms, where I've taken anxiety, health about. There is no rubric like anxiety about parents like that or anxiety about mother, but I've taken this rubric, anxiety, health about of relatives. This is common but very, very important. Why? Because this is very persistently present in this particular lady. Mind, fear, health of loved person, about health of loved persons. Parents are naturally loved persons, and she's having a fear about the health of her parents, whether they will get deteriorated, whether she has to come down from Mumbai. So these things I've taken. And finally, the main fear I've taken, the peculiar fear, that is a fear of downward motion. So this was a total repertorization. Repertorization is not a sum total of symptoms, but the main symptoms, the important symptoms, which will actually give you a picture of the patient, that has to be taken. So that is repertorization. It is based on the dominant symptoms, and the most peculiar symptom was the fear of downward motion. Now, after repertorization, we find that this is the result. Mercurius is coming, cocculus is coming, ammon curve is coming, arsen is coming, calcare is coming, natrum curve is coming. Natrum curve is very important. Phosphorus, borax, they are very important. But I was not very satisfied with this repertorization. So I tried to go for some eliminating symptoms, where I have to go for the main symptoms without which we cannot construct this case. So I went with some eliminating symptoms. I have taken, trimmed down some of the symptoms from here, and I've taken only 4 symptoms, which I think were very important for the final analysis. The main symptom, that is sterility, was taken. Sterility with leukorrhea was taken. Leukorrhea was taken because leukorrhea, if you go through the Mathematica, you find that leukorrhea of the cervical discharge, sometimes this becomes a very big problem in cases of female infertility. And the peculiar mental symptom, that is a mind, fear of downward motion, was taken. Because anxiety for the parents, anxiety for the loved ones, that is important. That is a dominant symptom, but that is quite common. So I have not taken it. I have taken the fear of downward motion. So after the final repertorial analysis, this was the picture. Now borax is coming. Borax, creosote, natrum curve, calcarea curve, stylisha, they are coming. And I selected borax because of the mental concomitant. The first prescription was on 9th of October, borax 200, and husband was given testosterone 6. Why? Husband's semen quality was okay, the semen was, everything was okay, but still I prefer to give some medicine to the husband because I do not want to take any risk in these cases. So he was given testosterone 6 empirically. This is an empirical prescription, but this was a selected prescription for the particular patient. Now, if you go through Kent's Mathematica, if you go through borax chapter, you will find that Kent has written all these women. I'm just, quoting some of the lines. All these women are sterile. All who have such symptoms are sterile, and borax has cured sterility when this condition was the cause. Now, what is the reason? Reason is, according to Kent, this acute leukorrhea, this false membrane forming and being thrown off. It is no wonder that women are sterile. That means this particular discharge is actually preventing the sperm from reaching the fallopian tube. This is causing the sterility in this female. There's another drug, natrum curve, that is also having this particular symptom. So I selected borax in this case, but in some cases where you find symptoms of natrum curve, you can go for natrum curve also. Date of second consultation, I've given borax. Second consultation was in December, 19th of December. Consultation was done on phone. Every time it was not possible for her to come down from Mumbai. So she consulted me over phone. The last period was on 28th of November 2024. She had dysmenorrhea, but the dysmenorrhea, the pain was much less. Flow was much better. Last time it was 2 days. Now it is better. And she was feeling better in all aspects. She was feeling better in all aspects. That means regarding the fatigue, regarding the tiredness, and she was getting more interest in work. But the main thing, she hasn't conceived till now. So finally, she told me that, doctor, I have not conceived till now. So our problem is not solved. This was in 19th of December. I took the mental symptoms once again. Though she was feeling better physically, she was not better mentally. There was anxiety regarding pregnancy. Now you see that anxiety is shifting in its focus. The anxiety was regarding her parents. Now the anxiety is gradually increasing regarding her pregnancy, whether I'll be able to conceive. So this shifting focus is very, very important. What is the dominating symptom? That is very important in cases. And this anxiety was maximum when she was alone in the home. Sometimes she used to take leave from the office. She was alone. Husband was went to the office. So she was having the maximum panic attacks, anxiety problems when she was alone. And sometimes she used to feel that she was a failure because she could not conceive. And now after talking to her over phone, she was, I could understand that she was now becoming desperate to become pregnant. So this desperation was not there in the first visit, but I could sense this desperation in the second visit. So these things are very, very important, this change of mental symptoms, and we have to change our drug accordingly. In this case, the psychosocial aspect is very important. So we have gone through the investigations. There was no problem with that thing. So we have to emphasize on the mental symptoms. The psychic state of the female might be the main hindrance to the conception. Hence, the mental symptoms were taken into account and repertorized as follows. I've taken the main symptoms: sterility, leukorrhea, anxiety. These are all general symptoms, general mental symptoms. Fear, failure of. These are the new symptoms that I've taken. That, doctor, I am a failure. I cannot become a mother. This fear of failure, this is very important. And she was getting desperate to become pregnant. So mind, despair. Sadness. Another thing I would like to tell you, that depression, you won't find the term depression in repertory. You will find sadness in repertory. So sadness, gloomy, sadness during menses. This is very important. And anxiety when alone. So in this repertorial analysis, I have gone for the mental symptoms mostly. And after this repertorial analysis, I find that the first drug that is coming was phosphorus, because it is covering the maximum number of symptoms. Though the maximum points arsenic was getting because of the anxiety, but it was covering only 7 symptoms, whereas phosphorus was covering 8 symptoms. So there was a tussle between phosphorus and arsenic, which one to give. I prefer to give phosphorus, because from the looks of the patient, from the appearance of the patient, she was more of phosphorus, number one. Number two, I did not find the typical restlessness in this patient. Arsenic patients are mentally and physically restless. But in this patient, I did not find the physical restlessness. Though she was, yes, restless, she was becoming desperate to become pregnant, but the physical restlessness was absent. So I preferred to give her phosphorus. On 19th of December, she was given phosphorus 200, and I continued with the empirical prescription of testosterone 6 for the husband. Third consultation on 28th of February 2025. Information was given on the phone. The husband called me, told me that my wife had the last menstrual period was on 23rd of January. The consultation you find after 1 month, 28th of February. It was in 23rd of January. 1 month has already crossed, and they have already done an ACG test in the home. The spread color test was done. This is a picture of the kit that he did it on 27th of February. You can find the date over here. And he called me on 28th of February. So in this spread color test, there were 2 lines over here. This is the control C, and this is a test. So normally this control line will be red, and if the female is infertile, if she is unable to conceive, this will not become red. This will be white. So once this becomes test, this becomes red. So you can finally conclude that she has conceived. Now, after that, I asked them that you can go to a gynecologist and you can do an USG. They went to the doctor on 10th of March 2025. The last date was 23rd of January 2025. You see, 23rd of January by LMP, the age of the zygote was embryo was 6 weeks, 4 days. What was the conclusion? Single live intrauterine embryo of 6 weeks, 4 days, but there was irregular sac margins. So there was some doubt. This irregular sac margins, that's also not a very good sign. Though there was a single live intrauterine embryo. This live is mentioned because his heart rate is present. Just last week, I got a case from Calcutta where that lady had to undergo medical abortion because she had conceived, but her baby, the embryo was not having any heart rate. So the doctors could not find heart rate even after 2 or 3 sonographies, and finally she had to abort. She had to undergo medical abortions. So this heart rate is very important. So now it's confirmed. This is the most confirmatory test that whether the lady has conceived or not. So 10th of March, it was finally, confirmed that she is pregnant. After 2 weeks, she went for another sonography. That was the final sonography that I'm having in my hand. Second USG on the 9th week, 26th of March. You can find the conclusion, the comment by the radiologist is single live intrauterine embryo or fetus. Now you see the irregular sac margins that is gone. Now she was actually continuing phosphorus till now, I remember. And after this report, I told her that now you can go to any gynecologist or obstetrician you like over there in Mumbai. And now they are under the care of a senior physician over there, for senior gynecologist. And she is doing very well. She's keeping in touch with me and she is better. And after that, doctor advised her that you can go for another blood test also. This is another very recent test that they're doing. That is beta HCG test. This is a serum serological analysis. Beta HCG, normal, non-pregnant female. It's around 5.3 milliliters. And she's having 3386. So the HCG levels are very, very high. It shows that she is pregnant. Human chorionic gonadotrophin levels are very high, signifying that she is pregnant. So we have solved the first case with homeopathic medicines. Definitely we went through the repertorial analysis. I haven't gone through any empirical prescription for the patient. I've gone through, I've analyzed the case. I've gone through the mental symptoms. I've taken all help with the RadarOpus and I've selected the medicines. And with phosphorus, finally, this lady was being able to conceive after 2 years of trial. So this was the first case. And the next case I'll be moving on very fast. This is a very young lady of 20 years. She came to me last year in 2024. 1st of February, she came to me. She has been married for 2 years, trying for a baby for the last 1 year. But she has never conceived. For the last 1 year, she had been trying continuously. They have been trying to get a baby, but she never conceived. So this is also another case of primary infertility. Initially, in the first year, there was a short history of intake of oral contraceptive pills. Clinical history, menarche at 15 years. This lady also started, having menstruation at a late age, 15 years. But from the very beginning, there was irregular menstruation. There was 2 to 3 months amenorrhea, and then she needed help with the medicines, and then she had menstruation. So this irregular menstruation is very important. Duration of each period was 5 days. There was history of clots, pain in the back and abdomen on the first and second day, congestive dysmenorrhea, and she needed painkillers. White discharge, that is cervicitis before and after the menstruation. The last case had white discharge for the whole month, but this case had white discharge before and after the menstruation. The last period was on 5th of January 2024. Other symptoms, past history, nothing abnormal. Father history, hypertension, mother history, nothing. I got nothing. Because she's 20 years, so mother is also very young, I think. Then stool was regular, urine, there was no problem. Perspiration maximum on the face. Appetite was normal, but she preferred sour food. And she was suffering from dyspepsia. After eating foods, there was some sort of acid reflux and the mouth was getting sour. Mind, patient was less responsive and less cooperative. In this case, what happens, the husband was more responsive, the husband was more dominant. So the patient was less responsive. She was not answering my questions. Anyways, I was trying to get answers from her. And I could find that there's a tendency of easy weeping in this lady. And after questioning, I could find that there was a fear. Specifically, there is an apprehensive fear of remaining alone. Why? Because this lady, the husband is working in the police department in my city, and this lady is staying in a place called Purulia, which is around I think 250 or 300 kilometers from this place. So working in the police department, her husband could not go every day, even every week. So she has to stay alone with her in-laws. So sometimes she was very, very apprehensive of remaining alone. So after getting this case, nothing more I could get because I told the patient was less responsive. I advised some USG and blood tests, and I asked the husband to undergo semen test also. I went through a repertorisation, RadarOpus, mind weeping, mind 4-second feeling, because she was feeling alone, as if her husband has left her. So she was having a 4-second feeling and fear of being alone. I have taken the mental symptoms in the first part, and I have then taken only the menstrual symptoms, that is, the menses are irregular. I haven't taken sterility till now. I went for this repertorization quickly. It was repertorized and pulsatilla was diagnosed. It was covering all the 5 symptoms, having 11 points. Argentum nitricum then was coming with 4 symptoms covered, and following Ignatia, lycopene, phosphorus anyway. So I prescribed pulsatilla 200 for this particular lady on 1st of February 2024. For the husband, I did not give any medicine because everything was normal for the husband. Date of the second visit was on 29th of February 2024. The last period was 23rd of February 2024. Flow was profuse and clotted. And they did an USG on their own. 4th of February, the USG was done. There was mildly thickened endometrium, no uterine embryonic sac. So she has not conceived. And they also did this PrEG color test in their home. You can see the control is red, but the test is white over here. So this particular image shows that she hasn't been able to conceive. Second pregnancy, second prescription on 29th of February. There was no change in the symptoms, so I persisted. I repeated pulsatilla, and husband no medicine. Third visit was on 8th of April 2024. The LMP was on 4th of April 2024, duration 5 days. Slight delayed dysmenorrhea. There was cramping in the back muscles, but there were no new symptoms. They did an USG again, and the blood test had advised. Now, this was the pathological investigations. Serum prolactin was 12.7, normal. Thyroid levels were normal. Hemoglobin was 11.8, quite normal for an Indian lady. Toxoplasma, IgG, rubella was slightly out of range. This is called torch profile. Sometimes this causes hindrances in getting pregnant. Testosterone level was normal. The other female hormones was normal, and this AMH was also normal. This AMH is very important. She was a non-diabetic, HbA1c was normal. USG abdomen, mildly thickened endometrium, and there were multiple small cysts. That is, PCOS features was found in the particular lady. So this might be the reason for this infertility case. Husband's semen was done. Normal morphology was 80% of the sperms were of normal morphology, and motility was around 84%. So everything was normal for the husband, and the lady was having some features of PCOD. The pathological, the serological reports were almost normal. I went for a repertorization with the Now, in this repertorisation sheet, I have taken all the mental symptoms that were present in the first visit, and I have added this sterility rubric, sterility. And I've added another two, that is pain, cramping pain, female from the female genitalia, and back pain during menses. These two symptoms are added. So new symptoms were added, and pulsatility was again coming. You can find. So if you take the right symptoms, the right drug will be coming. So pulsatility is still the drug of choice for us. Pulsatility was given on 8th of April 2024, and for the back pain, I started Viburnum opulus 3x. This Viburnum opulus, I did Viburnum opulus, number one, the back. And number two, if you open Boric, you can find Boric that Viburnum opulus actually prevents miscarriage. This is a drug which is mentioned in your Mathematica that it very often prevents miscarriage. So in case of female infertility, if you doubt that this might be a case, there might be a case of miscarriage, abortion, so you can give in addition to the constitutional drug Viburnum opulus, which will prevent scope of miscarriage. Date of fourth visit was on 7th of June 2024. Last period was on 4th of June. Leukorrhea before menses. There was pain in legs, abdomen, nipples before. So she was having some sort of premenstrual syndromes. But mark the last menstrual period, that is 4th of June 2024. Next, the patient did not report. The husband came to me. The fifth and the last reporting was on 12th of July 2024. 12th of July 2024, the husband came to me, and the LMP was still 4th of June. So in July, she did not have any menstruation. That is amenorrhea after June 24. And she conceived. You can see this PREG color test. Now both the lines are having red color. Now we can actually tell that yes, she has conceived. Still, I advise her to go for a USG. They went for a USG on 14th of August 2024, and the radiologist gave this report, that is single intrauterine gestational sac, 6 weeks 1 day in the lower endometrial cavity, and she gave another advice to go for another follow-up checkup on after 2 weeks. So on 11th of she did this on 14th of August. The last period was 4th of June, and she did it on 14th of August. So it's confirmed that she has become pregnant. She went for the final confirmatory USG after 2 weeks. The same thing, 7 weeks, 6 days. The embryo is now 7 weeks, 6. That means almost 8 weeks. The embryo is almost 8 weeks old. Now it's confirmed. And I told them that now you are having your baby inside. Now you can go for a gynecological checkup with a senior gynecologist in your place, and you can be under her care. Now this is the latest. I told you in the very beginning that the latest infertility case that I solved is of this particular boy. He was born on 31st of March 2025. Her father reported to me, sent me this photograph that, sir, we have been blessed with a son who was born on 31st of March 2025. So these were 2 cases that I shared with you from my own practice. Now I will be going very fast. I don't have much time. Repertorial, some of the rubrics that I have selected for you. These are some of the suggestions from the mind. Grief, sterility from. Mind, reproaching oneself, sterility with. Mind, anxiety, abortion after. Mind, fear, failure of. Mind, despair. Mind, stress, overwhelmed by stress. I got a case very recently, I told you, where the lady was compelled to undergo medical termination of pregnancy because the embryo was not having any heart rate. And that lady was complaining that, doctor, I am very much stressed because of my mother-in-law. So these sort of things, the stress from the family members, from the mother-in-law, from the in-laws, this is also having a big toll on the infertility problems. Sadness, this depression rubrics is sadness. Now, I've taken some screenshots from the RadarOpus. This is the main rubric that I very often refer to, female genitalia chapter. You have to refer to the rubric sterility. A lot of drugs are there you can find. Aurum, borax, natrum cub, natramule, sepia. Then female genitalia sterility accompanied by ovarian cysts. accompanied with leucorrhea. You can find over here Netrapcar, borax, creosote. Then infertility from copious menstrual flow, borax. So all these subrubrics are very important. You have to take the general rubric first, and then you have to take the subrubric. When the patient is having, blaming herself, you see, doctor, there is some problem with me, I cannot conceive. So you can take female genitalia sterility with this mind reproaching oneself with sterility. This is also a very important rubric you can refer to in cases of female sterility. With excessive sexual desire, this is also a very important rubric you can consult. So these rubrics, the sub-rubrics, you have to consult with the repertory always, and that only can help you in solving these cases. If you go for tumors or cysts in the ovaries, you have to refer to this rubric, female genitalia. Tumors, ovaries, cysts. This is a general cyst. It can be a hemorrhagic cyst, it can be a simple cyst. Then, if you want to find the rubric for the polycystic ovarian disease, you have to refer to this rubric in synthesis, female genitalia, menses absent in polycystic ovarian syndrome. This is a rubric for PCOD, where you can find drugs like aristocracia, clematis, helleborus, estrogen, progesterone. These are the drugs. So I will always tell you that please go through the repertory, always take the symptoms correctly. Go to the repertory rubrics like this. These are the physical rubrics: female genitalia sterility, female genitalia, copious menses in sterility, frequent menses in sterility, late menses in sterility. All these rubrics I have selected for you, but these are not the only rubrics. You have to take the case, and you can find all these sorts of references from our repertory, and you can always consult the repertory physically or on the laptop, and it can help you solve these cases. So this is the way that I try to solve my cases of infertility. These are some of the other suggestions: menses absent, polycystic ovarian syndromes, tumors, ovary cysts. These are all the rubrics that I've collected for you. Female ovaries, complaints of. You can find the history of abortion, personal history of abortion. This is also an important history. I've never been well since the abortion. This is also an important symptom. So these are, symptoms, these are rubrics which are all scattered around in our repertory. You have to consult all these rubrics in solving the cases of female infertility. Thank you very much for your patient hearing. This is a brief presentation from my side.
So, Dr. Partha, thank you so much for your valuable time.
Thank you. Thank you very much for giving me an opportunity.
Thank you, sir. Thank you so much. Thank you, sir. And if we will have any other webinar in future, so we would like to invite you with us.
Thank you very much.
Thank you, sir. Thank you so much. It was very nice to have you. Thank you, sir. Goodbye.
Okay, goodbye. Goodbye. Have a good day.